My name is Jonathan Fite. I'm going to give you a little more introduction on me in a second. But thank you all for being here. This is actually really, really exciting in my view. And it's about as geeky as exciting gets because we're in it now. But the fact that all of you are here, the fact that folks from Epic themselves are here, I think actually speaks volumes. Not only about your commitment to interoperability, which, as you all know better than anybody, it's kind of this ginormous myth that Epic doesn't like to share data. And I actually have a slide. You may see reference. Well, if we get to it, you'll see reference. That actually refers to the ability of Epic systems to share data. And then we talk. So what sort of the predicate for a lot of this today is that as I talk with folks all over the country about interoperability, patient tracking over time, data management, and analytics, and so on. So much of the discussion sort of boils down to Epic, Cerner, Meditech, McKesson, et cetera. They all like to share. They just don't like to share with you. And there's a reason for that. There's actually a couple reasons for that, and vice versa. They have trouble historically getting the data from pre-hospital as well. The fact that you're all here and that we've had a session yesterday in the afternoon with a number of different departments from as far away as Green Bay and even an on-site that I had earlier down near Milwaukee in the morning, really I think underscores the fact that this is a hot topic. Everybody in this room and people on the phone and people who couldn't make it today are interested in the idea of sharing data, moving data around, tracking data over time. As someone who's been in this business now for actually 10 years as of May 1st, that's a pretty substantial sea change. Even just in the last 18 months or so, there's been a totally different approach to the idea that data is information and information is power and knowledge is power and so on. And so the ability to move information around, but also understand where the roadblocks are and how we can get around them. The part of this conversation that often raises eyebrows most when I talk about them is the idea that there are standards for doing this. You heard the first two people who mentioned problems with one particular technology company. There is a change afoot in the EMS business, and when I say EMS, I mean fire as well, just for clarification purposes, is about 5 years behind the rest of the healthcare IT system in terms of interoperability and data sharing, data tracking, recognizing that there are opportunities for seeing where people move around the healthcare system. So the fact that you're all here, the fact that you all are here, not to point too directly at you, but the truth is there was a conference a couple years ago I attended in DC where the Assistant Secretary for Preparedness and Response, ASPR, which everybody on this side of the room at least knows about, large-scale disasters, federal management, and whatnot. ASPR's involved in that. NHTSA, the National Highway Traffic Safety Administration, was there, which controls NEMSIS, the EMS data system, and the folks who were not in the room were CMS, which is the ones who pay the bills, right? And the entire meeting sort of came to a crashing halt as soon as someone raised their hand and said, "Why are the people who make the payment rules in the room?" Having one of the substantial stakeholders absent is a huge gap. And historically, we have found that conference after conference, event after event, magazine issue after magazine issue, topics like interoperability and patient data tracking, and even getting off of paper and why that's valuable and worth the effort, tends to get lost because the other state, it's an echo chamber. Everyone who's hearing themselves know that, or at least believes it, which is why they're self-selecting to attend those sessions. We don't often have the other people who need to be in the room on the receiving end, for example, attending. So it's actually this is a huge milestone, I think, for everybody here and for the industry, that the folks who are on the receiving side, hospitals, and the data systems that you guys partner on are represented here. Hopefully that becomes a trend that we can start looking at consolidating across the industry. So with that, the topics of discussion today, as you know, we're going to talk about the data exchange, health information exchange, and tracking patient over time. Try to cover it from a couple different vantage points, not just from a clinical perspective, which tends to be where things start and end in the EMS business, but really from the operational side and the technical side. I'm going to get a little geeky. If any of this stuff sounds confusing, complicated, hopefully not too complicated, but if it does sound confusing or if you have any questions, please do speak up. I can talk for a legendary amount of time. I just don't necessarily want to. So a little bit about me, since I'd like to say our company works at 26 states and 3 countries, so there's 24 states that have never heard of us. But Beyond Lucid Technologies is a technology company. We were actually, when it comes to the National EMS Information System, NEMSIS, we were actually the first company in the industry to comply with it. And we've been first in a number of states. So we sort of swim around in this data longer and deeper than most people in the business. But I'm here not representing a product per se, but rather, as you saw on the prior slide, just to highlight it, the Brain Trust of Fire and EMS Technologists is our consulting division. And by that, we publish a lot. Some of you may have seen, you have a white paper set in front of you. If any of you didn't get a copy, there's a couple copies still over here. That's the large booklet that is really about how you do this sort of stuff. Again, interoperability and data sharing and data tracking can sound very confusing. It can sound kind of magical. You'll hear stories today, I'm sure, as I talk about conferences where resolutions have been passed about all the access that pre-hospital providers should have to electronic health records, not knowing that A, it ain't going to happen, and B, it shouldn't happen. And so understanding the why it can or can't or should or shouldn't, or what would need to happen to make it possible if it turns out that the law has changed and so on, is really what we're all about. And so as an organization, we kind of hide in plain sight because we publish this stuff and kind of invite folks like ImageTrend and Zoll and ESO and Health EMS and others to catch up because, quite frankly, they're a bit behind the times when it comes to information sharing. Personally, I've taken that content to places like GEMS, Journal of EMS, which I'm a columnist for, EMS World. I'm going to flash it right now, but we're going to come back to it a little bit. Writing articles like Why Data Interoperability Matter. And talking about the fact that if you're tracking patients, for example, who are addicted to harmful substances, and you don't have any idea what the other EMS and fire services in your general vicinity are doing, your patients do. They're round-robining the system to get whatever meds they want to put in their bodies. And if you don't have any way of tracking that, we got a problem. The urgency on these matters, some of them at least, is increasing, and so that's why I've been out there trying to tug an industry forward when it comes to the data part, because it can seem very scary. Let this be hopefully a starting point, maybe a bottom line for today, is that if you know how to stick a tube down someone's throat, or you know how to reach into a car and pull somebody out without breaking their neck, and you know how to put out something that's burning, it's a whole lot more complicated than sharing data. But it can seem remarkably scary when it comes to the amount of information that's captured, and of course the burden placed on your practitioners and clinicians to capture that data, to validate the data. And I think because of that, because of the way that the mandates have been pushed down onto our industry, there's not been a lot of explanation around what their value is, and that's really what today is all about. I do come in with some respect for the role of government and what government is good at and what it's really bad at, like messaging, what its intention is and vision and so on. Because actually, if any of you have ever used the website USA Jobs, which is the federal government's hiring website, I actually was one of the members of the team that redesigned it. So big government project down to individual user. And that's really sort of the advantage that we bring to trying to make sure we understand what the user's experience needs to be and what the effort is on you as agency leaders to convey to your crews, and what the challenges are when you have a rolling training, right? And people coming and going out of your departments all the time. So these burdens can seem very high, and we found that that's the same, by the way, on the hospital side as well. There are people who come and go from an individual department. Your internal champion that knew exactly everybody in your department that was your best friend is now somewhere else. And how do you start over? And so much of the conversation has tended to crash on the rocks of that personnel mobility and internal politics. And so we're trying to make this more about understanding the science so that you can understand where how to pick up where you left off. I use the words at the top of this page very intentionally. This provocation was instigated by LifeQuest Services, and I was thrilled that they came to us. It's been actually pretty wonderful partnering with LifeQuest. I just want to make sure I throw out the kudos to you guys for being on the front edge of that, and to Chuck Apple for really trying to push the industry forward, be a thought leader when it comes to interoperability, understanding the purpose of the data, not just that you need to collect it, but why. And again, that the juice is worth the squeeze, to use a bit of a strange colloquialism. But we do want this to be thought-provoking. Each of you within your own regions is a thought leader. The fact that you are here suggests you are self-selecting for things like not just innovation, but connectedness. In that same spirit, I hope you'll go back and talk to your regional providers about the value of what they're doing. I mean, If one puts 10 fire EMS agencies in a room and asks them how they like their technology company, you're going to get 12 reasons why you hate it. The irony, and I'll start with this with due apologies to our colleagues here from elsewhere, is possibly the only thing more hated than electronic patient care records in this industry are electronic health records on the hospital side. These are, but again, a lot of that's because of the way they've come down to the providers on the ground and sort of been data driven as opposed to person driven. And the evidence for that on the hospital side, which again, far more complicated even than EPCR, is that the industry has been moving to scribes, literally following doctors and nurses around hospitals, taking notes for them instead of having the clinicians writing their own electronic health records. We complain about EPCRs sometimes taking 15 or 20 or 30 minutes to do. Here you've got an entire head count dedicated to getting your documentation done. So this is a pretty substantial problem. And again, there's been a sort of a mystique to the EMS industry about what goes on the other side of the handoff. But these challenges exist in both places, and I professionally live in both worlds. So what I'm trying to do is sort of slam them together, and I've been thrilled to find at least this many people in one location through one partner who was able to bring people together and say, this is something we need to start to tackle. So I can only imagine if this is the beginning of a movement, all of a sudden these lines start to collapse, to cross, and that's really exciting. So the kind of a lot we're going to cover today, and again, feel free to please step in. If you need to step out, do that. I realize everybody here is on the clock one way or another, so certainly don't want to be disruptive, but hopefully we cover a lot and it becomes a lot to think about. Well, by the way, even before I transition, let me say, again, I'm not here representing a product to the degree that I may have to mention one at some point, sort of apologize in advance. It's more about bringing examples of things that are being done as opposed to pitching. My expectation here is that everyone, show of hands who's using an EPCR of some kind in the room. Beautiful. My expectation is that you will keep doing that, and probably with the one that you have. If you hate it, I'm happy to talk to you afterwards about something that you might love. But that's the only time you're going to hear me talk about pitching a particular product or not. This is really about the knowledge and the science and enabling you to go back to whatever company you're working with and say, hey, at this event, I learned X, Y, Z. Here's the citations. Why don't we have a conversation about that? Because we are in 2019. I strongly believe, and we had some conversation about this yesterday, I suspect we may today as well, one company of any brand does not need to own the process anymore. And that is what the electronic health record side of the world discovered about 5 or so years ago, when the emergence of organizations like the Commonwealth Health Alliance and Care Equality came and basically said, you know what, we're gonna allow everyone to recognize that a lot of these issues that we are dealing with in terms of patient tracking around a healthcare system, for example, affect lots of different hospital systems. Some are going to use Epic, some are going to use Cerner, some are going to use, well, Centricity is not really around anymore. But, there's all these different systems, and then there's doctors' offices and nurses and clinics, and why is anyone trying to own the whole process, instead recognizing that there are parts of it that we can share? People have to protect the data. You want to make sure your patient's privacy is protected and the information is maintained and continuity and all those things. But other than that, no one really needs to own the whole thing. And the EMS business is still not quite there. Getting there. But there are still whole states that require mandatory the use of one particular vendor. That can be really great from a data interoperability perspective, unless that system has an outage in which you're all SOL. There are risks to de-diversifying, and there's also benefits to doing it. And I want to make sure we talk about what those are, because there's a lot of move now to start sharing process, and that's number 9 here. So I'm a little ahead of myself. So first we're going to talk about the vision. Why this even matters, the concept of connected health and healthcare, of which EMS and fire are a part, and not just provider too, but as everyone who wears a patch in this room understands, that you are the tip of the spear. I'm not a clinician. Actually, our company is the only technology company in this industry that was founded by 2 non-clinicians. I'm an MBA, Carnegie Mellon, my business partner as well. Found my way into this industry vis-a-vis the military. If I seem a little twitchy today, I promise it's not you, it's me. I have Tourette syndrome. It turns out Tourette syndrome and the United States Army don't really go all that well together, but I tried. And I was training to be a medic, like I said, didn't take. So it really does give you a sense of what type of technology does not exist out there in the suck. And it turns out that battlefield medicine and rural civilian medicine are nearly identical. So there is anyway, that's sort of how we got into this business. But because of that, we've focused on business process problems, as a pair of MBA technologists can do, looking at the value of data sharing, for example. The critical statistic that got us focused on this part of the business was discovering that officially, per the literature, just about 50% of critical patient data are retained on handoff between every pre-note of pre-hospital care. So basically, you transport a patient for 15 minutes, get X number of sets of vitals, whatever other critical situational information, you hand that off to someone at a hospital, maybe they get half of it. You hand them off to a second provider from fire to EMS, for example, for transport, maybe they get half of it. That's terrifying and really expensive. It's also really dangerous from a legal perspective. It's dangerous from a clinical perspective. There's a whole lot of waste that goes on there. And so we recognize that if you plug that hole, you got yourself a business, right? This idea that if you could have data flowing through the system, what could we do with that? Imagine the ability not only for information to flow from the truck back to billing and get that information processed faster, but wouldn't it be neat if you could have an insurance card, for example, sitting in the hospital before the truck even arrives, have a bracelet ready to go, be able to have context on whether this patient, it sometimes can be tough, and there's been write-ups, of course, about the difficulty of pre-hospital providers diagnosing Bell's palsy versus stroke. Turns out the fundamental decision point is context on whether the patient has risk factors for stroke or doesn't. You need historical information for that. So the ability to provide information in a not just a bidirectional fashion, which is what so much of the discussion is, but really kind of like a cloud, where it's moving where it needs to go, and whoever needs to see can see and make sure that information is correct. That's really what the vision is. We're going to talk about that. In order to empower that, there need to be data standards. And the upside of that is your tax dollars are already paid for them. I can tell you that when I give presentations like this elsewhere, the jaws tend to hit the table when I mention that there are standards for data sharing. EMS just really hasn't partaken in them. There's not really a whole lot of good reason why. In fact, the first bridges to connect NEMSIS to the HL7 via those standards were implemented in 2015. Getting the word out has been a little more challenging, but the technology has been there for nearly half a decade at this point. So we're going to talk about what those standards are and how the data can move between them, as well as why simplifying those standards is a problem. Just about 2 months ago, I was in Phoenix as part of the Mobile Integrated Health Network sessions. I was actually the only technology company represented in the room, which is a little crazy. And there was a deputy chief from one of the fire departments who's involved in this mobile integrated health program, who literally said, there were several groups. There was fire, EMS, me representing technology, insurance providers, and the program managers who are affiliated with a foundation that's funding these efforts. And one of these fire departments basically said, look, we're firefighters. We want to simplify the documentation as much as possible, ideally not have to do any. To which the insurance company and I both kind of looked at him and said, you're in the wrong room. If you want to fund a community paramedicine program, no matter who's funding it, it's a data-driven process. And one of the things I hope you'll take away today, and again, I'm sort of previewing where we're about to go, is would it blow your mind if I told you didn't actually need to take any specific people off the line or assign specific teams to build a mobile integrated health program that is wildly successful, even profitable to your organization? Not that needs to worry about sustainability, but that is inherently stable and inherently growth oriented and returns revenue back to your municipality or to your private service or to whatever it is. It's a data game. Mobile integrated health is less about the way that you engage with your patients on the ground and more what you do with keeping track of them over time. That's a very different way of looking at these programs, and rather than seeing it as a FTE driven process that becomes very expensive, it's about slicing and dicing your data to increase the knowledge of who your patients are that are rotating through your system over and over and over again. In order to do that, we need to embrace the idea that these standards have a purpose, right? And the more that we simplify them, the less we gain, the less we benefit from the granular knowledge that they provide. And that is a bifurcation this market is facing right now. On the one hand, it wants to connect to the rest of the healthcare system. That requires process control. On the other hand, it's saying there's too many questions in NEMSIS. Agreed. But I don't think it's actually the number of questions, in my view. It's what the questions are asking that is largely useless. And with the exception of the ones that are geared towards interoperability, are we in fact asking things that matter? That's a very different kind of question. And because providers typically aren't at the table when it comes to discussing the type of data that need to be captured, these things are being fed to you and shoved down your throat, and you're being told you're going to like them. That's a problem. as opposed to saying, why don't we figure out what you actually need to ask and then use interoperability as a framework. So we're going to go into that. That leads to this next bit. Myths and missing pieces. HL7 you heard mentioned, NEMSIS you heard mentioned. Show of hands if you know what an ICD-10 code is. Show of hands if you know why an ICD-10 code is. That's very different. Think about that. Show of hands if you know what HL7 stands for. No, actually stands for. Yeah. Okay, we'll get to it. Health level set of action. So we'll get to that. But the point is, this is, again, if let's take the HL7 part's not really important. The ICD-10 one is. So if almost no one in the room who's actually filling in the data knows why you're capturing that and why we needed to move from ICD-9 to ICD-10, because by the way, it has no direct relevance to being bitten by a salmon a second instance, or struck by lightning after getting run over by a horse cart. Like those are, yes, they're silly and we like to sort of point those out, but the truth is every single one of those things has relevance. It's happened somewhere. Those are really the understandings or the underpinnings of these frameworks helps make them more tenable, as opposed to, geez, we have more drop downs we have to deal with. And so to me, and sort of the sum total of this, box number 5 here, is that the future of connected EMS is the future of our industry and the ability to see people over time. Whether or not community paramedicine as such remains, as it's with that title, no one really knows, right? But the idea that there are patients round robining the health system, unfortunately, the drugs aren't going away anytime soon. And studies are showing, and NPR is reporting that wherever opiates get cracked down on, methamphetamine is coming back. And when meth goes down, crack is back. People who are addicted are gonna be addicted, and we need to engage with them. But the idea of the return of the house call, which is what community paramedicine kind of is, isn't really going away. It's gotten root and it's working. So now we got to make sure that we prove it so that people understand how to engage in it. So I look at it as sort of the future of the program over the industry. And also begs the question, and it's one that I hope you'll start thinking about now. Community paramedicine has a lot of politics and baggage associated with it, funding questions and yada yada. What's the difference between a community paramedicine program and a drug diversion program or opioid avoidance program? Answer: the name, pretty much, to the exception of the nature of the patients you're going to see, but for the most part, it's basically the name. And even in places like California, where you have very strict rules around how you can engage a community paramedicine program, there's nothing that says you can't take care of your patients in a proactive manner. I have never encountered a single community with a drug problem that doesn't know every one of its addicted patients. Right? You know who they are. You can see them over and over again. They're sticking things in their bodies that aren't supposed to be there. This is not somebody overdosing on 3 Vicodin because they have a busted hip and they, forgot that they took a pill. Although in some cases they could be elderly and doing exactly that. But nevertheless, the idea that if you have a drug problem, you have a drug problem. You're going to see these people over and over again, and those issues lead to other chronic problems down the road. So chronic care bleeds together. The longer we live, the more these are going to come up. This is the future of our industry. Understanding how the pieces touch is probably valuable. And along with that, keeping these programs alive. So what I've been calling community paramedicine 1.0, these programs have largely died. And they died not necessarily because they needed to. They died because they hadn't planned on how to keep living. So I want to give you the concept to think that rather than talk about sustainability, which basically says I don't need to take my tin cup out every so often and ask someone to put more in it, what if you turn these into a source of revenue for your organization? We're going to talk about some ways of doing that, but I can tell you yesterday morning I blew an agency's mind. They literally said that when I explained to them that, consider, what is the single worst thing that could possibly happen to a nursing home from a marketing perspective? Ambulance rolls up in front and then sits there for 2 hours. Lights going, do an investigation, wheeling somebody out. You're a nursing home, you take care of people, and all of a sudden people are dying, getting sick inside your institution. What is the marketing value to a nursing home to build a program such that you, coming in as civvy clothes instead of with badge on, come in and check on those patients a couple times a week so you can keep them from having the MI or stroking or falling and being proactive about it? They'll pay you for that. It is worth it from a marketing perspective for a private institution like a nursing home to do that. That becomes a business. And so the chief that I mentioned that to yesterday said, are you turning this into salesmen? Well, kind of, but you're selling yourself anyway. You're just selling yourself to somebody else when you're asking someone to put something in your tin cup. So if you're going to your department, you're going to your city, or you're going to a foundation, all you're doing is selling. You're just selling to somebody else. And so we can tie value to these programs. All of a sudden they become revenue centers for you, as opposed to I want to be a part of the club, or I think it's good for my community, but I have no way how to keep it going. So let's think about that. And I want to tell you about a success that just happened last week. If you look at EMS World or GEMS in the last couple of days and type in 300-mile transport, you'll see it. And it was the case of how health information exchange can work when an agency transporting from Tulsa, Oklahoma, 300 miles to North Kansas City by ground because they needed specialized hospice care for a liver cancer patient, had the data show up at North Kansas City Hospital before they got there. And there was no engineering involved whatsoever over that 300-mile transport, I can guarantee you. So the idea that data can move around the system if enough nodes participate in it, and what that can do for efficiency, patient care, and financial performance, even in terms of not having to worry about what's where and has the social security number been captured for billing purposes, et cetera, et cetera. There's some very powerful capabilities there. And the last thing, again, we're sort of where I started, is the idea that this is not any one company, and it cannot be any one company. Each of you in this room utilizes a technology vendor, with an S at the end of that, for how many different things that you do. And it is a very fair lament that you have to log into multiple different systems to maintain your operations. A lot of those times those systems don't talk to each other. EPCR doesn't talk to hospital. Scheduling may or may not talk to EPCR. Inventory management rarely talks to EPCR. And if I were to talk to you one-on-one about your individual context, my starting question would be, how many times have you asked the vendors to connect? You ever pushed them? You ever told them that if they don't, you're going to find somebody who will? This is not a dynamic that, and certainly as someone who runs a company that builds those, I beg for people to hold us accountable. It's our job to do that. And yet I go across the country and I hear people complain about the same problems over and over and over again, knowing what they are, and yet continuing to live with them and not holding anybody accountable. Our industry needs to be held accountable. It should be held accountable. We are supposed to be serving you. And it's one of those things is by connecting those dots that rarely ever gets asked. And often it comes down to not knowing what can be done. They're all zeros and ones at the end of the day. The majority of the technology challenges that are faced end up being business decisions, not technical ones. So hopefully that's something that you guys think about as we start on the industry side, the data side, I should say, talking about coalitions between us so that we can start having standing bridges between our systems. And that if you work with one, you can work with the other, and we can share data, and you can have regional approaches to care and interoperability and data sharing. Okay, before I dig into some of the meat of this, any initial questions, thoughts, concerns? I've thrown a lot at you. Good? Perfect. Okay, if at any point, feel free to raise your hand, stand up, throw something at me. I'm pretty accessible right here. And if at any point anyone's dozing off, I will try to be funny or something. Okay, so the big picture vision. I think you all know this in your bones, but sometimes it can be hard to wrap our minds around the pieces of the process that come together to do it. The concept of a connected and informed EMS fire and EMS system as part of the healthcare information cloud. I'm going to use that term a couple times today, I think. Goes back to this concept I was starting to mention or this incidence of a transport from Tulsa to North Kansas City, 275.1 miles. The idea that information needs to get where it's going from the place that it's starting, and doesn't start necessarily in the back of the truck, but there's context to that patient. I mentioned this was a hepatic cancer patient, for example, that needed hospice care. You can imagine how much information is being summarized, right, when you look at or you're sort of coming together in the incident of this patient needing to be transported, right? There's a lifetime coming before. And imagine the situation where you're driving at, say, 50 miles an hour for 275 miles. You're going to be in the car for a while together. Wouldn't it be nice if you knew something about your patient beyond the fact that they need to be transported and they have liver cancer? One of the things that we'll get to, hopefully if we have time today, is about the relation, some of the financial underpinnings of things like community paramedicine and the remarkably compelling and really sad research happening now into the clinical value of eliminating loneliness, right? I mean, loneliness is a remarkable driver of healthcare decline. And so the idea that if you knew, for example, imagine if your community, we talk about community health and knowledge and connectedness, imagine if you knew that your patient who you're seeing for whatever reason over and over again has a pair of grandkids that she hasn't talked to in a year. And maybe the extent of your community paramedicine program is you call her every other day to say, hey, how's it going? How's your knitting going? When's the last? How's your grandkids doing? Something that gives that person something to look forward to. Um, Connected and informed doesn't just mean having access to the electronic health record. It's recognizing that there's a person behind this, right? We're all in this business. By the way, show of hands, who got into this industry to do paperwork? um, yeah, I tend to actually, usually, well, sometimes I get one person who actually does, and it's usually an accountant or something. Um, but again, the idea that there is healthcare knowledge, there is information that's contained within various health records. Most of the patients who land in your lab are not doing so, out of the blue. They've been seen before for one reason or another. Having a sense of what their context is, but also understanding that there's probably more than you're going to get. Because the technical capabilities don't exist just yet, or they're just rolling out now in the form of something called FHIR, stands for Fast Health Information Resources. It's not misspelled. And it's essentially the ability for you to request of a electronic health record only the information that you need for your current encounter. That technology basically hasn't existed for the last several years in any meaningful fashion. So there's a reason you haven't been able to get context out of healthcare systems that don't have a way of only giving you what you need to know. But if you did have more information about that, there's a lot that you can do, and there's a lot that you can maintain on your side that is not necessarily resident in electronic health record. But at the same time, you're taking these patients somewhere, whether you're transporting them in an ambulance or in a QRV, if you're doing a community paramedicine program, or wherever. Basically, information needs to get from one place to another. And in 2019, we're still talking about faxes. I happen to know there's a EPCR company out there that actually just introduced a fax server into its software like 3 months ago. What? And what year is this? Right. So the very idea that we are having conversations about that, the very idea that a hospital expects that, again, to dispel a myth, the hospital wants to hear from you by phone looking for information even less than you want to call them. They're busy. It's really expensive. And they have no desire. Is that a fairly accurate statement? Okay, perfect. So one of the challenges, among others, with fax, besides the legibility question and the fact that paper and ink are remarkably expensive, is time and security and having to OCR and scan and correct the scan and shred the document and file the document and yada, yada, yada. And yet we're still talking about faxes. And so at the Society of Trauma Nurses conference back in March, where I gave a presentation about the overlap between data for trauma and data for community paramedicine, interesting topic, another time. I'm happy to tell any of you that's interested in that. There were 3 separate presentations at one conference by completely different organizations from different parts of the country, literally using the words, "We are begging for pre-hospital data in our hospitals. We need EMS information. In fact, we can't do our jobs without it." How is it that everyone on the EMS side thinks that hospitals don't want our data? That seems weird. You're here, and they're literally begging publicly for the data to come through. Something is clearly getting missed. And so I sort of ratcheted up my volume. It was pretty loud before, but I ratcheted up my volume since then because there is clearly something being miscommunicated somewhere. I think we need to find that out. And part of what we're going to end up talking about today is the relationships and the politics and a little bit of an inferiority complex that pre-hospital care has for its role in the ecosystems. And this idea of sort of we have to go with what the hospital wants, and we're the little guys, and they're big and they have so much money and power. Yeah, you kind of have a lot of power too. In fact, there's a guy named Bob Kocher, who I can't imagine most of you know, but he was one of the authors of the Affordable Care Act, now a venture capitalist in San Francisco. And he once said to me, when he got into the venture world out of government, "I don't know why EMS get treated so badly. They bring in the revenue." Yes. So if you start to think of yourselves as that, it changes the relationship. It recognizes that the brass on the lapels means something. And in fact, I can tell you, and I will show you a copy of a letter that was just sent by a very small EMS agency in rural Minnesota to one of its largest hospitals in its area, still not huge, but part of the Sanford Health System, so it's a very large hospital system, that informed them that as of June 17th of this year, they will no longer receive faxes. They weren't asking permission, they were providing information. That is a process that is being replicated in places across the country. I would encourage you to consider taking such a stance, but we'll come to that. But as you're looking at the why of sharing this information, we get into, the fact that chronic care on the one side is going to get worse. People are getting older. They're living longer. There are initiatives in San Francisco to have us live forever. Not really sure how we're going to feed everybody, but that's not my problem. I think it's probably all of our problem, actually, as I think about that out loud. But, we talk about CHF and COPD and fall risk, diabetes, et cetera, cancers, post-surgical, monitoring, sepsis, all of these issues that fall into these types of managed care programs. There's a lot of context about those patients' lives and how they got there, and the need to know what is being prescribed. And at the same time, there is also this concept that the information that's taken care of in a 911 context, for example, is, the public still thinks scoop and run, right? Would we agree? Right? Take the patient, drop them off somewhere, go on your merry way. We all know there's a whole lot of information that needs to move around the system. And so the discussion of how that happens is again, what sort of meat of today is about. But it really requires the recognition that all parties have a stake in that. This is not EMS and fire wanting information that others don't want to give it because they don't want to give it. It's a question of how, and it's a question of why and how fast. And are you getting this information? For example, if you hand over information electronically to a hospital 72 hours after the patient's reached the ED, what does that do? There are certain systems that do that. You probably know some of them. Their trigger to send data to a hospital is the close of the call, which can take some time to get done and QA'd and ready to hand off. Consider the legal risk to the hospital if they receive your data 3 days after the patient was there and they missed something that they needed to otherwise know. It's a massive malpractice risk for them. Our friends over at PWW, for example, do a great job of underscoring a couple legally sound, really efficiently kind of not great messages. One is if you don't document it, you didn't do it, which is, again, that's great from a legal perspective, perhaps, but it leads to PCRs taking hours to do. Also makes our software in general a stick as opposed to something valuable. And the other is the idea that if you take your time to get all the data right and hand it off, and it becomes a legally valid receipt, basically, right? I mean, think about it. If you consider let's use an inside message in sort of a public context, but the concept of patients as packages, right? The public conception of pick up X in one location, take it to another location, get it signed for. FedEx does that, right? As clinicians, you're doing a whole lot more than that. But the way that the documentation that my company and others develop has been treated like a receipt. And if you didn't write it down and you get dragged into court, someone's going to say you didn't write the thing down, therefore you didn't do it. Or billing, right, uses that information. If you're not maximizing what you're documenting, then you're not going to get all the money that you're owed. No wonder people hate EPCRs. All they see is threat, right, instead of seeing the opportunity to share information. And so what I would encourage you to consider, and I emphasized to Chuck last night a little bit, that a lot of this power rests in the hands of the state and the data managers and NEMSIS in general and so on. But if you can take your data exchange, and again, if you can sort of take this concept and you make it not about handing off information for CYA benefit, but instead you make it, what if we turn this document to something that is both legal and clinically valuable? It changes the dynamic and the relationship that you have with the data itself. It's not about keeping yourself safe in court. It's about making sure that you are conveying what you know, the knowledge that each of your clinical teams and that you have spent time and blood and sweat and tears and money training them to do properly, which they're handing off by voice now. Right. And so I mentioned that the research shows that about 50% of data are retained at handover, and anecdotes show that it's more like 20%. Maybe you get some demographic data. And I was talking to a department recently that said, I guess it was just yesterday morning down near Milwaukee, that said they get in their trauma center, they get precisely 30 seconds of quiet time allocated to explain their story. I said to them, okay, let's assume that's actually what you're going to have. Let's assume that's your hospital process, for better or worse. Wouldn't it be neat if you could spend that 30 seconds actually conveying stuff that matters, as opposed to like 28-year-old female? Duh, she's sitting right here, right? I could have conveyed that information using an app as opposed to spending the time my 30 seconds telling about the fact that her demographics are present. If she's either awake or she's not. I mean, you can see that. But if you have 30 seconds, you can convey what the medicine that you did and the context of why why she's in your hands in the first place. All of a sudden, that time is used more valuably. Even better if you could start to convey that information into a source whereby someone utilizing Epic, for example, could walk about the hospital and see what's coming in. Right? There are terminals all over many hospitals. Right? The ability to see that on screen, touch the EHR, not have to go to other places, is not just a holy grail. It's something that we can achieve. I mean, the technology exists to do that. So that gets back again into sort of the nuts and bolts of this vision and how it becomes real. We identified it really in three buckets. The first is, as we say, the ability to capture a patient's information at their side in the field quickly and efficiently. Show of hands, how many folks are doing PCRs in the field at the patient today? Okay, so for the most part. How many of you are sharing that information in anything like real time? Okay, so that's our opportunity, right? That's where we focus on. Again, that's the reason for bringing everyone here today. I think it's very compelling, and hopefully, by the way, you guys, and from the hospital side, you see this as just as compelling as I do, right? Folks are here saying, we want to be able to give you this data. Now the question becomes, how do we do it? What do we do to educate the market on the opportunity to do that? And the third is the ability to track that patient's information over time. And again, if you think about patients as packages, not necessarily the greatest PR message in the world, but pretty accurate. When you actually think about what it is that you're capturing, it's highly fragile information, that contents of this package that you're transporting. The ability to know where you started from, know where you're taking that to, and why, and you can track that information over time, and you can see how it's moved and who's taken custody of it, and so on and so forth. I just recently got involved in a fascinating project. Assuming that we get the funding, it's through either the Department of Homeland Security or DoD, I forget. But it's digital triage tags. I mean, we still use paper triage tags. What are we talking about? Okay, the fact that that's a reality still boggles my mind. But isn't it a neat concept when you think about, for example, the tragedy in Las Vegas and the idea that you have 250 people spread out across the system, and there was no tracking of those patients at all. But you have cloud-based technology, you have great internet connections, and you have the ability to say, bleep, bleep, when you leave, and bleep, bleep, when you arrive, right? Why aren't we doing that? So the concept of this connected ecosystem, again, it's not just something that we should do, but it's something we can do, and that also starts to engage the rest of the patient's health story. And this is what, again, brings it back to the role of pre-hospital care as the starting point of a healthcare encounter, as opposed to, as some have described it, the delivery to the healthcare encounter. And I think about, in this case, my own personal context, and one of the things that keeps me going in this never complicated, always straightforward business, is my own dad. So my dad's a diabetic transplant patient. And so if something, hopefully nothing ever happens, but if something did, it'd be great if EMS knew who he was when he arrived on scene. It'd be fantastic if the hospital had some idea when he arrives as to the fact that he's in like 4 different registries. Who I really want to know is my mom. Because as much as I love my dad, he's a little too stubborn to wear a bracelet, and my wallet is not quite as bad as his. But if you think you're getting an insurance card or an ID out of it, good luck, George Costanza style. So now you're in a context where wouldn't it be great if someone could say, notify my mother that he'd been picked up and that something had happened and he's being transferred and where he's going and he can meet him there. This vision was conveyed to me, as I always like to give credit where it's due, by a fellow named Mike Metro, who's the now former deputy chief of Los Angeles County Fire. And it was one of those 5-minute conversations that completely changed my world. I'm really glad I had it. We were at the California Fire Chiefs Association meeting a couple years ago, and he explained this in the context of something he called EMS 2020, which apparently now is getting kicked out to EMS 2050. I'm not entirely sure, by the way. I think we should be talking about like EMS 2019 third quarter, but that's just me. And he puts his phone down on the desk in front of me, and he said, why is it that I can check myself into a flight right now, but I can't check my patient into the hospital I know I'm going to? Good question. So that's what we're doing. And that requires a communication across an ecosystem, right? It's not one company doing that. It's lots of companies doing that. It's electronic health records. It's interchange capabilities. How many of you have heard of a company called Pulsera? Right? So, look, the guys at Pulsera are brilliant. Good friends of mine, and we've had some fascinating conversations about the idea that they pivoted their business a little bit. They were once upon a time talking about pre-hospital notifications for you guys, so if you don't already know about them, pre-hospital notifications of things like stroke and STEMI en route to the hospital. And they realized that there was an even bigger opportunity than that. It's a fine way to start a business, but it's kind of a one-off. But managing the pipes about who needs to know about what's getting messaged that's a business. And so they have sort of shifted their business a little bit to routing messages for intra-facility communication. So the information that you're sending up, say for example from an EPCR, and figuring out who's on shift today at the ED, who needs to know about it, so that the stroke fellow who's down with his family in Disney World isn't the one who's getting the notification, as opposed to the person who's covering for them today. And that the management of that process requires collaboration of a number of different systems. But that's the vision. And again, there's not any reason why that can't be done. And once you get there, what really becomes compelling is what you can do with the data to understand your health system.